Hi there, this is James, and today I want you to get ready to experience a supercharged metabolism and a thrilling ride with Graves' disease using some various unique medical mnemonic. So buckle up and let's start with a medical mnemonic for the clinical features of Graves' disease. Clinical manifestations of Graves' disease. Using the mnemonic metabolish, patients may complain of menstrual abnormalities, thyroid myopathy that presents as muscle weakness or even muscle breakdown. The skin may be moist and velvety. There is also pretibial myxedema, which is also known as thyroid dermopathy or localized myxedema. It usually results from the infiltration of dermis with glycosaminoglycans that causes this thick, scaly swelling of the lower legs. There can be emotional liability. Exophthalmos is the protruding of the eye, and if this occurs beyond the orbit, we call it proptosis. There may also be erythema or palmaerythema, tremor, the risk of thrombosis because there is an association with arrhythmias, especially atrial fibrillations. The body temperature may be elevated, there is a bruise sometimes, and these bruises may be systolic or continuous. There is weight loss despite an increase in the appetite of the patient. Reflexes may be brisk. Orbitopathy, there is another section that I have devoted to talk about orbitopathy, Graves' orbitopathy. There is osteoporosis because the bone turnout is very, very high for the osteoblasts to even catch up. There might be diarrhea because thyroid hormones can also activate catecholamines. There is insomnia, irritability, and sweating excessively. And there is also heat intolerance. Graves' orbitopathy. Fibroblasts in the eye cavity seem to play an important role in this disorder. It interacts with cells such as the T cell, B cell, macrophages, and mast cells. On the surface of the fibroblast are TSH receptors as well as insulin growth factor 1 receptors. Now, the generation of antibodies, such as the TSH receptor antibody, may in fact attack the receptor, the TSH receptor. And similarly, the IGF-1 receptor antibodies may attack the IGF receptors. That leads to an activation of the fibroblast. There is a robust reaction from the fibroblast as a result of the increased cytokines and the interaction between these cells. So that leads to adipose tissue proliferation, adipogenesis. These fatty cells will build up in the cavity of the eye and cause problems. There is also excessive hyaluronic acid production. The net effect is soft tissue involvement. There is also orbital muscle fibrosis that may restrict eye movements, proptosis, optic neuropathy, and eyelid retraction. The clinical features of Graves' orbitopathy may easily be memorized with the mnemonic Graves' oculi. There is grittiness, gaze-evoked pain, redness, the rectus muscle hypertrophy or fibrosis may lead to double vision, afferent pupillary response abnormality, visual field and acuity impairment, eyelid retraction. And here I would like to explain because eyelid retraction is one of the most common symptoms of Graves' orbitopathy. So the second picture that I have here is a great or a typical example of eyelid retraction. First, let's see what the limbus is. So this is the limbus. And normally the upper eyelid should cover the limbus by about 2 millimeters. Like the picture on top, we see that the upper eyelid covers the limbus by about 2 millimeters, and the lower eyelid sort of lies just exactly on the lower limbus. That is the normal variant. But in eyelid retraction, this is the type of picture that you would see. That is abnormal. There may also be exophthalmos, and that can also lead to progression, in other words, proptosis. Keratoconjunctivitis sicca is dryness, ophthalmoplegia, optic nerve swelling, chemosis, which is edema of the conjunctiva. Some studies have shown an intraocular pressure elevation on upgaze. Lid lag, which is known as von Graefer's sign, is the upper eyelid refuses to go down on down gaze. Whenever you look down, your upper eyelid must also go down. But in Graves' orbitopathy, the upper eyelid will stay, just like we saw in eyelid retraction. Lag of thalamus is the inability to close the eyes, and there may also be infrequent blinking. So, one of the key investigations to do is a thyroid function test. And we do know that anytime there is excessive thyroid hormones and those hormones were not signaled by the TSH would almost always suppress. So, in Graves' disease, which is a primary form of hyperthyroidism, there is a generation of antibodies. And these antibodies disguise themselves as the TSH and they are able to stimulate the TSH receptors on the thyroid membrane. So the effect is going to be release of hormones. And that hormones, since TSH did not signal that, it is going to lead to a depression or a suppression of TSH. Radioactive iodine uptake is an important component of the evaluation of Graves' disease, and it helps measure the functional state of the thyroid gland, whether the gland is underperforming or normal or hyperfunctioning. In other words, we will say that a high radioactive iodine uptake is directly proportional to the hyperfunctional state of the thyroid gland. What it means is that more synthesis of hormones is high function. More synthesis of hormones, if this is indeed done by the thyroid gland, would lead to an increased radioactive iodine uptake. Now, let's use some examples. In multinodular goiter, there are hot nodules. These nodules produces excessive thyroid hormones, and that will lead to an increased radioactive iodine uptake. In contrast to subacute thyroiditis, where there is a decrease in the radioactive iodine uptake, the reason is because the architectural integrity of the follicular cells may be disrupted due to the inflammation of the gland, and so there is no hormone production in subacute thyroiditis. The hormones are rather seeping into the blood from a sick follicular membrane. Hence, the functional state is low, and that will lead to a decreased radioactive iodine uptake. Antithyroid drugs should be stopped several days prior to the test, around maybe 3 to 4 days. The normal values for a radioactive iodine uptake is about 5 to 30% of the uptake is considered normal. So a patient usually runs to the laboratory where they are given some pills or a capsule that contains radioactive iodine 131 or 123, and the patient comes back in about 6 to about 24 hours, and a gamma probe is placed on the neck around the thyroid gland to assess radioactive iodine uptake. Now, in order to be very definitive and conclusive in the investigations, antibodies must also be checked to help aid the diagnostics of Graves' disease. So we have the thyroid stimulating immunoglobulin, which is also known as the TSH receptor antibodies. Ultrasound may also play a role, especially if there are thyroid nodules in a patient with Graves' disease. It helps to evaluate thyroid nodules and can be very useful in nodules that are not even palpable, because in about 25% of the cases, patients with Graves' disease may actually have a nodule. It may also help distinguish cystic lesions from solid nodules and will help guide fine needle aspiration. So, in the 25% of cases where there are nodules in a patient with Graves' disease, a fine needle aspiration would also be indicated. Treatment of Graves' disease. Here we use the mnemonic traps, and I think it is unique because it is directly related to Graves' disease. So I think it will help you easily memorize the treatment modalities. Thionamides example includes carbimazole, propylthiouracil, and methimazole. These agents inhibit the synthesis of thyroid hormones at the level of the thyroid peroxidase enzyme, iodination, and organification. Now you do recall that the iodides get into the follicular cells and they are converted into iodine by the thyroid peroxidase enzyme. And so if the thyroid peroxidase enzyme is inhibited, that will of course lead to an inhibition or a decline in the synthesis of thyroid hormones. It also inhibits the iodination and organification, which is the incorporation of the iodine into the thyroglobulin backbone. Propylthiouracil inhibits the peripheral conversion of T4 into the active T3 hormone. Generally speaking, thionamides are teratogenic, but the preferred one is propylthiouracil during pregnancy. It can cause hepatotoxicity. One important thing that I want to really emphasize on is agranulocytosis. So patients that are started on these agents can have signs and symptoms of infections, and so you'd like to assess the full blood count and make sure that there is no neutropenia because this can in fact lead to complications such as sepsis, among other unwanted complications. Radioactive iodine ablative therapy has been approved for Graves' disease, among other disorders such as multinodular goiter, toxic adenoma, and some forms of thyroid cancer. The follicular cells pick up the radioiodine, which concentrates in the thyroid tissues and emits beta radiation during the decay process, which destroys the thyroid tissues. It is contraindicated in pregnancy, children, as well as severe Graves' orbitopathy. Regarding teratogenicity, it is recommended to wait about 4 to 6 months after the treatment with radioactive iodine ablative therapy if there is the wish to conceive or father a child. Complications are many, but hyperthyroidism is very important to note. Beta adrenergic receptor blockers. It is a known fact that thyroid hormones potentiate the effect of catecholamines, so these agents will help inhibit the adrenergic effects and ameliorate symptoms such as the elevated heart rate, tremor, anxiety, panics, sweating, and the heat intolerance. Block and replace is a strategic treatment plan where a high dose of an anti-thyroid drug such as carbimazole is given to block the thyroid synthesis, and at the same time the patient is given L-thyroxine as a replacement therapy. But the truth is that about half of the patients using this modality may actually have a relapse that would eventually need surgery or radioablative therapy. Surgery, a subtotal thyroidectomy, may be indicated in pregnancy, in children, when there is an adverse effect from medications such as the thionamides, a compression from a goiter, in severe Graves' orbitopathy, or in patients that are not compliant with their medications. Complications may include nerve damage. Specifically, we want to talk about the recurrent laryngeal nerve, which will present as hoarseness, a high-pitched voice, and a noisy breathing. Other complications would include bleeding, hypoparathyroidism, hypothyroidism, and infections. Sodium iodide is also a drug that contains iodide, and they inhibit hormone release and also blocks peripheral T4 conversion into T3. Thank you for watching, and if you find the content useful, then subscribe to the channel. Bye.